Welcome back. Myself is Professor Somnath Dash taking the third class on the general management of poisoning. This is the penultimate class and we'll be taking another class after this one. We have divided this class as far as the treatment is concerned into two halves because in one class it may be monotonous or it will take a lot of time to make you understand the intricacy of this treatment. In the last two classes, we have already discussed how these poisons are classified, what are the different types of poison depending upon its action. We have also looked into the analytical toxicology part. We have also discussed what will be the role of a registered medical practitioner and also the method of treating a patient at the emergency level, which is common to all the patients, irrespective of poisoning or non-poisoning. Now in this class we'll be discussing about the treatment part. As we have already shown and we have already told that the management includes both investigation as well as treatment. We have covered mostly the investigating part in the previous class and now we'll be doing the treatment. When a patient is being transferred from emergency to the ward, it is better to transfer the patient in the left lateral position, which is also known as the recovery position. The reason is very simple, that in this position the chances of aspiration due to vomiting etc. will be much less. When the patient reaches the ward, we can place the patient in this position or in a position where the upper part of the body will be slightly elevated, again to reduce the possibility of aspiration of vomitus. At the emergency level, we manage the patient by these three important aspects. The first one is the history taking, the second one is the physical examination, and the toxicological screening. If we have not done at the emergency level, we can do this toxicological screening at the ward also. History taking, physical examination, and toxicological screening. These are the three important and the main headlines in which you people have to all give your answers when you are asked to give a management of a specific poison. We will discuss it one after the other. This is the first thing that we'll have to be doing when a patient comes at the ward. We'll have to take the history. Apart from the normal history taking, in these cases, that means in the cases where there is a suspicion of poisoning, we'll have to take some specific history of that specific poison. That means what is the agent, if it is at all available, and the amount that the person has taken, what is the time and the location of exposure, that is what is the route in which the person has taken, and whether the person has taken any other substances along with, because we have seen a lot of cases where the patients come with a history of multiple poisons. Apart from that, we'll have to also take the circumstance of the exposure, when the person has taken and what was the circumstance in which the person had actually taken that specific poison. Whether the person is having any kind of current medication in order to rule out the possibilities of pre-existing diseases, and any kind of past medical history or pre-hospitalization treatment. We have seen a lot of patients who come, has been treated at the rural hospital level, and there the doctor might have given all the things that initially has to be done, so that there is no repetition of those things. It is better to take the history in that manner. Apart from that, we'll also do the physical examination, and as far as the physical examinations is concerned, we usually look for the four important systems to see what are the different changes that is happening, because these are the four important systems which are very important, and they are being involved in the poisoning. It includes the heart, the lungs, the abdomen, and the neurological examination. In the heart, we definitely look for the rate, rhythm, and the regularity. As far as the lungs, there are the most common poisons like that of organophosphorus, which causes huge number of bronchoria and wheeze. In abdomen, we look for the bowel sounds as well as the tenderness and rigidity, because most of the corrosives, they changes these kind of parameters, and definitely the neurological signs symptoms will have to be looking for it, because in huge amount of ingestion of different poison, the commonest manifestation that the patient comes with is coma. So to rule out all these things, these are the four important aspects, or the four important systems that we will have to look for, and look for the changes that is happening in these four systems. So these are the steps that we usually take while treating a patient. These steps are stabilization, decontamination, elimination of poison, antidote administration, and nursing and the psychiatric care. So these are the five steps, and whenever you people are being asked to give any answer to the question of a specific type of management of any poison, please try to follow all these five steps and give answer in that manner. The steps of stabilization does not mean to start with giving any kind of antidote for the specific poison, but it tries to control the basic instabilities with which the patient usually come to the emergency as well as to the ward. It includes the correction of the hypothermia or that of the hyperthermia. It also includes the correction of the hypotension or that of hypertension, and it also includes the correction of the arrhythmias or the seizures. We would rather start with the discussion about how to control or how to stabilize the patient. The first we will be talking about the coma and hypothermia. The thing is, please remember that this coma and hypothermia go hand to hand. Usually when there is hypothermia, the patient comes with coma and vice versa. Whenever we'll be talking about what are the drugs that causes this coma and hypothermia, please remember that you need not have to remember all the drugs. What I have done is that the common drugs are usually given in the first, second, or the third examples in the slide, and you are to remember all these things. So, as it is written, the common drug that causes hypothermia includes the antihistaminics, as well as the sedative, the hypnotic drugs, mostly the benzodiazepines and the ethanol. These are the common drug that causes hypothermia, but from that there is other list also, which also includes the opioid, which is not very uncommon as far as India is concerned. When we talk about hypotension, the drugs that commonly causes is the beta blockers, mostly the antihypertensive drugs, and the disulfiram. Please remember that as far as the children are concerned, one of the most important toxicity includes the iron toxicity, and the patient, usually the children, present with hypotension. Apart from that, there are other poisons which includes the cyanides, the carbon monoxide, as well as hydrogen sulfide. These three components causes hypotension. Now, when we try to eliminate the hypotension, we try to eliminate the effects of these drugs. The treatment of hypotension in a case of poisoning includes a lot of components, but it usually depends upon the nature of poison that is causing this hypotension. If it is a tricyclic antidepressants or the sodium channel blockers, we usually treat the patient with sodium bicarbonate injection. Now this injection is given is a bolus dose, which is near about 50 to 100 milliequivalent. If it is due to beta blockers, the drug of choice for treating hypotension is the glucagon, which is given as 5 to 10 milligram IV. If it is a calcium channel blocker, we give calcium chloride, and the dose in this case is 1 to 2 gram IV. The common drug that causes hypertension has been tabulated in the slide. If you find that the patient is suffering from acute hypertension, apart from taking the history, you should also inquire the medications that the patient was taking. If the patient had been taking any of these amphetamines or the anticholinergics, then we can have an idea that might be due to this hyperactivity of these two drugs or ingestion of these two drugs, the patient is suffering from hypertension. MAO inhibitors is another group of drug that causes hypertension. Please remember the amphetamines and the anticholinergics as a common causative agent for hypertension in these cases. Now we come to the treatment of this hypertension. Please remember that we are stabilizing the patient. We are not going to treat the specific antidote at this junction. We are doing only stabilization or correcting the derangements that are initially the patient is suffering from. Please remember another important thing, that in most of the cases we do not get any kind of specific antidote. Moreover, there are possibilities that the patient is unable to say what kind of poison the patient has taken. So, it is very important to correct these derangements. We come back to the discussion. If the patient is suffering from hypertension with agitation and anxiety, it is better to give lorazepam. If the hypertension is persistent in nature, we usually give sodium nitroprusside solution. When there is hypertension with excessive tachycardia, the propranolol is the drug of choice. There is a caution that has been given. Please remember, do not give beta blocker alone, since doing so may paradoxically worsen the hypertension as a result of unopposed alpha adrenergic stimulation. When you people are doing the chapter on these beta blockers and the alpha adrenergic stimulation effect of it in pharmacology, you can jolly well understand what is the reason for that. The next thing that we will be considering is the arrhythmias. The common arrhythmia that is seen is the sinus bradyarrhythmia and the atrioventricular block. In both the cases, it is caused by the beta blockers and the calcium channel blockers. The commonest one being the sinus bradyarrhythmia. If you were given any kind of MCQ, please remember that this sinus bradyarrhythmias, as far as the beta blockers, is the commonest arrhythmia that is seen. Apart from that, there may be a wide QRS complex or the sinus tachycardia, as it has been very clearly written here. But please remember one thing, that arrhythmias may also occur as a result of hypoxia, metabolic acidosis, or that of the electrolyte imbalances. So, the arrhythmia which are being caused by this need not have to be treated. It is always better to look into this matter beforehand we administer any drug in order to control the arrhythmias. So, we will have to see whether the person is having a normal saturation of oxygen or that of there is any signs of metabolic acidosis or electrolyte imbalance. If we correct all these things, then in all probability these arrhythmias will go away. So, we will have to look into this matter before going or supplying any kind of medicine to these patients who are having arrhythmia due to different type of toxicity. Please remember this slide, because as we have already discussed, if there is any kind of electrical imbalance, then we'll have to correct it accordingly. Mostly the ventricular arrhythmias, which are said to be life-threatening, are controlled by the lidocaine or amiodarone, and the dose is usually the usual antiarrhythmic dose. If it is caused by the tricyclic antidepressant, again as we had seen earlier, We administer sodium bicarbonate at a rate of 50 to 100 milliequivalent IV bolus dose, and we have seen that in most of the cases these are corrected. There may be torsidis pontis or digitalis induced arrhythmias. They can be corrected as it has been seen or it has been shown by magnesium or that of the digoxin specific antibodies. The last one is not very common, that is the chlorinated solvents. Here the treatment of choice for controlling the arrhythmias is the propranolol. Please avoid the class 1A antiarrhythmic agents which may aggravate arrhythmia which is caused by the tricyclic antidepressants. So, whenever we come across a patient with drug overdose, the treatment has to be a bit cautious because there are a lot of drug-drug interactions. Next thing that usually the patients suffer from is the seizure. There is a wide range of drug that causes. There are a wide range of specific so-called poisons that also causes seizure. The most common of them are the amphetamines, the cocaines and the antidepressants. Please remember that organophosphate compound, which is the most common causative agent as far as the toxins are concerned or the toxicity is concerned as far as India, also causes seizure. And there are some secondary causes just like the arrhythmias, hypoxia or hypoglycemia or hypocalcemia also causes this seizure. Before administering any drug, it is again advised that you have to look into the electrolyte imbalance and try to correct it. Maybe that simple thing, it will get rid of these seizures caused by any kind of toxin without administering specific drug for correction of seizures. If it is not so, then we move on here. Lorazepam is given 1 to 2 milligram or diazepam 5 to 10 milligram IV over 1 to 2 minutes. It is very slow IV infusion because there is a propensity to reduce the respiration or the respiratory rate as far as the people are concerned. So it has to be monitored and then we'll have to give diazepam as well as lorazepam. If IV is not available, then we can give midazolam as 5 to 10 milligram IM. If the convulsions continue, then it is better to give phenobarbital. So the basic common drug that we get in most of the hospitals is the diazepam, and you can jolly well administer diazepam, but please remember that we should have a look into the respiratory rate before doing or during the time of administration of diazepam. The next is the hyperthermia. As we had already talked about the hypothermia. The hyperthermia are caused by the amphetamines, the cocaine, the salicylates, and the common another component nowadays which are very often used as a psychiatric drug is the SSRI, that is the selective serotonin reuptake inhibitors. These antipsychotic drugs usually causes hyperthermia in high dose. Please remember that this hyperthermia is a very dreaded complication, but it can be treated very easily by administration of cold water. Removing the patient's clothing and spraying the skin with tepid or cold water and fanning is the most common method of reducing hyperthermia. This is the method that we usually do when the patient is suffering from high fever in our home also, isn't it? Muscle rigidity and hyperactivity, if it is along with hyperthermia, then in those cases we will have to go for the paralyzing the patient with a non-depolarizing neuromuscular blocker. And when the patient is paralyzed, then the patient has to be intubated and mechanically ventilated. The patient will be sedated throughout the entire process and will have to consider for a bedside EEG. Hyperthermia, which is associated with all these complications, the treatment becomes more difficult. But fortunately, most of the patient usually respond to spraying with the skin with a tepid water and fanning. This is one of the most important slide because here we are giving an information that the patient may be asymptomatic at the initial time of presentation. The patient may be very much apprehensive at the initial stage at the emergency, but when he or she comes to the ward, you have examined and will find that the patient is asymptomatic. These kind of symptoms are usually treacherous. Maybe that the patient has not taken anything and he or she is pretending that he or she has taken poison. In those cases, we will not consider that one. But there are some poisons where the patient seems to be very much asymptomatic or initially there is mild symptom. Please do not get carried away with this thing, because the list of poisons that usually do not show initial sign symptoms are given here. That is the reason that I was telling that this slide is a very important one. Please remember the names: ethylene glycol, organophosphates, paracetamol, the paraquat, methanol, thyroxine. There are others also, and it also includes another poison, that is rat killer poison, which is also known as the aluminium phosphide. Here the patient may come to you without any kind of sign symptoms or very mild sign symptoms. In those cases, there has been much more fatality where the doctor had thought that the patient might not have taken that amount of poison and the patient is being discharged. These cases, in these situations, it becomes very much complicated when the patient goes back to his home and again come back to the hospital with fulminant sign symptoms, or even the patient may come at the emergency broad dead. So you people have to be very much careful when you have a history of these kind of poisons. If you don't have the history, it is always better to keep the patient under observation for at least 24 hours, even if there is no sign and symptoms. This will at least reveal some type of sign symptoms at this time, during the time when the patient is being admitted and kept under observation. So please remember these things and we move on. Again, thank you very much for patient hearing. Hopefully you enjoyed all three classes. It would have been better if I could have taken it in front of you people, but in this corona environment, it became extremely difficult. Have a good day. Thank you again.